for inviting me. It's wonderful to be here. I'm wearing UCLA colors, even though I'm committed to Stanford for the past 40 years. I'm going to go backwards after these wonderful clinical research talks, and because I'm mainly a laboratory researcher, and the work that we are doing has not yet, the most recent work we're doing has not yet progressed to the clinic, but I will show you the data and where we think we're headed. Before I proceed, unlike the last speaker, I am occasionally paid. Whether I deserve it or not, I can't say. I was the scientific founder of Dendritic many years ago, 24 years ago, if you can imagine, that did develop the Provenge vaccine. And more recently, I am the scientific founder of a company that licensed our technology from Stanford for in situ targeting of dendritic cells. So I know I'm going to, the slides I'm presenting were prepared before the meeting, obviously, so I didn't know that there would be this much immunotherapy discussed, although I should have anticipated that since immunotherapy and the whole concept of immunotherapy has become center stage. Actually, I teach a course in tumor immunology. I've taught the same basic course at Stanford for the last 20 years, although it's evolved, obviously, as the technology has evolved. And when I started, there were 8 people, 8 graduate students that showed up for the course. Last year, there were 100 students that showed up for the course. We didn't have room in the auditorium for the. So it's obviously there's been a transformative change to the whole field, and it's both welcome, exciting, and a little bit crazy. But when I lecture on this subject, and I'm only going to speak for about 25 or 30 minutes today, but we go through a course that is 12-week course and 6 hours a week. So there's a lot that one could talk about, but at a 30,000-foot perspective, historically we viewed the tumor as presenting many barriers to an effective immunotherapeutic approach. In fact, until several years ago, most people thought this was an impossibility. The tumor environment is highly immunosuppressive. Tumors consist mainly of self components, and adaptive immune cells, T cells and B cells, are trained, if you will, during development to avoid attacking self. We used to teach and believe that this was due entirely to the elimination of T cells and B cells during development that had receptors that recognize self-antigens, and indeed that central tolerance phenomenon is alive and well, but it's incomplete. And what we didn't appreciate was the extensive peripheral tolerance mechanisms, including checkpoint molecules, that actually exist to control and prevent autoimmunity. Well, beyond these barriers, we know that tumors can escape most therapies, particularly those that target a singular molecular component. But ultimately, the goal of immunotherapy is to either bypass these barriers or overcome them and attack the tumor without harming the normal tissues. Well, we now know that despite all these barriers, the presence of certain types of immune cells in tumors, and this data is from colon cancer, at the time of diagnosis is actually a very powerful predictor of outcome. These data showed that depending on the frequency of memory T cells and memory helper cells, that the prognosis was drastically altered. And other studies, since these data were published, have shown this sort of pattern to be the case for most solid tumors. Now again, I'm being overly simplistic, and I apologize to the last speaker because I don't mention gene therapy in these approaches, but I like to separate these strategies into passive and active immunotherapies. The passive approaches are sort of bypassing the barriers, while the active approaches try to overcome them. Monoclonal antibodies were really the original bypass approach. These are what I'm referring to now are monoclonals that target specific molecules on the surface of tumors or stromal antigens. But in addition, more recently, we had, and you'll hear, I know about this later today, effector lymphocytes generated and modified ex vivo. These would include the original TIL expanded cells, but more recently chimeric antigen receptor lymphocytes. Really interesting, but also posing lots of challenges. On the right side, we have the efforts that are overcoming the barriers. These would include immunostimulatory molecules, various types of therapeutic vaccination, and also checkpoint antibodies alone and in combination with other molecules. Now, an early approach, perhaps the earliest sort of organized approach, was to proceed with immunotherapy based on tumor-binding antibodies. The idea here was that the tumor antibodies would bind to surface molecules preferentially expressed on the tumor and somehow, from that point on, induce tumor killing. Each antibody, at least in the beginning, recognized only a single molecular target, and they can work by either inducing some sort of killing or by inhibiting growth-promoting signals. These antibodies have become the standard for several types of tumors, B-cell lymphoma with rituximab, certain breast cancers with Herceptin, colorectal and head and neck cancers with EGFR antibodies, and so forth. And I show you here some of the earliest and most prominent data that were published around these antibodies, and you can see almost immediately as you look at this slide from one of the most important papers from the New England Journal, that the benefit from adding this particular antibody, Herceptin, to standard of care chemotherapy was incredibly modest. There is definitely a benefit. As you can see, in this Kaplan-Meier plots, the lower curve is a little bit lower than the upper curve where you have chemotherapy alone versus the combination. Interesting that Herceptin by itself offered very little benefit, but nonetheless, the benefit was sufficient to ultimately result in approval of Herceptin, and today it's a blockbuster drug. This is another example. This is rituximab, anti-CD20, for the treatment of malignant lymphoma. And again, you see that the benefit, while a bit more substantial here, and here again we're looking at combination chemotherapy and rituximab, and very little benefit if rituximab is used as a monotherapy. So the benefit is significant, but there are no cures. So to summarize briefly the advantages of tumor-binding antibodies, they're cost-effective in terms of their manufacturing. You have a one-size-fits-all, which means that's relatively efficient for the manufacturer. They're widely applicable. They're generally safe and well-tolerated, not always, but generally. The main challenges are their limited efficacy, and I would say that more recently, in the last couple of years, we've seen better efficacy with antibody drug conjugates and bispecific antibodies, and there's lots of activity and research going on with those. They are more potent. We'll see how they come about in terms of their safety and durability of response. A second early approach was one that I certainly was involved in, and that was the idea of using powerful antigen-presenting cells known as dendritic cells to stimulate anti-tumor immunity. So when I started this work, which is a very long time ago, back in about 1990, the view of the time was that the inability of the immune system to recognize and attack cancer was inherent and irreversible, due mainly to central tolerance, that is to say the elimination of T cells capable of recognizing a tumor, and also the immunosuppressive tumor environment. The new view, and I remind you that it's a relatively new view, is that effective anti-tumor immunity can be induced in a tumor-bearing host, provided that the right antigens are presented by the right cells and peripheral tolerance in the immunosuppressive environment can be overcome. But at the time we started, that was not the prevailing view at all. So these are these dendritic cells. They're present in almost all tissues. You can see why they're called dendritic based on their long dendritic extensions from for each of these cells has. And they reside in these many tissues, we believe, primarily for the purpose of surveying the environment and reacting when something comes in that shouldn't be there into the environment. So this is an illustration of this. The dendritic cells are generally born from precursors or progenitor cells in the bone marrow. They leave the bone marrow and circulate via the bloodstream to various organs. where in this case I'm using skin as an illustration. In the superficial layer of the skin, they're called Langerhans cells, and in the slightly less superficial layers of the dermis, they're called dermal dendritic cells. But both of these cells serve their hosts by sampling the environment, and if and when factors or infectious agents come along that are perceived by these cells as dangerous, and based on their interactions with the cells, many receptors, many of which are called toll-like receptors, not all. These cells then, once they interact with those dangerous molecules, they get very excited, they take them up, they phagocytize them, and they process their proteins, and then they leave their assigned sites. This is the only time during the lifespan of the host that these cells will actually leave, and they leave generally by the afferent lymphatic vessels, where they drain into the primary draining lymph nodes, and there they will present the processed antigens to T cells, mainly T cells, but they will also have mechanisms by which they can activate B cells and NK cells as well. So, and that's the mechanism, the main mechanism we believe responsible for generating what we call the primary immune response, the initial immune response. So dendritic cells are unique in that regard, and they do occupy a central role for some of us who in the immunology research field. So in 1992, when we started this original work, we recognized that dendritic cells were powerful antigen-presenting cells. We had developed methods in my lab for isolating these cells and causing them to mature and pulsing them with various antigens. And we came up with this rather simplistic concept that, well, what if we took these cells away from the immunosuppressive environment of the patient, pulsed them with antigens that were derived from the patient's tumor, and essentially injected them back in once they had processed those antigens and were activated, with the hope that they would find their way to appropriate immune organs and stimulate an immune response to the tumor. The way we did this was to have the patients come to our blood center, where they underwent a procedure to get a fair amount of blood out called a leukapheresis. It took about 2 hours. It's quite benign. We returned the platelets and the red cells to the patient and kept the very rare precursors of dendritic cells, cultured them in the presence of antigen, and after about 3 days, purified those cells and returned them to the patient, initially by intravenous infusion. Well, the first trial that we undertook was in malignant lymphoma. The reason why I did that was because I had a colleague at Stanford, Ron Levy, who was routinely isolating the specific immunoglobulins from each patient's tumor. So these are B cell tumors, and each patient had a clone of B cells, and therefore the immunoglobulins from the surface of those cells was essentially a tumor-specific antigen, and Levy made those antigens available to us for those patients who were unresponsive to standard of care at that time. So we prepared these cells, we pulsed them or loaded them with this antigen, and ultimately returned them to the patients via intravenous infusion. It was a happy story because we treated a very small number of patients. We were very nervous. We had no idea what was going to happen. But indeed, the first few patients we treated did in fact develop an immune response to their tumors. This is an example, a very nice example of a patient whose tumors were at these levels. So I don't know if you can see these, but there's tumor here. These are the two chambers of the heart and the tip of the liver, but there's tumor here, and after 3 injections over several months, the tumors had disappeared. This patient went into complete remission. We treated 4 patients. Now imagine this. This was, of course, at the time considered a pretty crazy experiment. 4 patients, all of whom had advanced, 3 of whom had advanced disease, and all of whom were unresponsive to standard of care therapy. This, of course, was pre-rituximab. And most of them responded, some of them rather dramatically, and we published a paper on the basis of 4 patients in Nature Medicine in 1996. It'd be hard to do today, but those were the early days, and it was a delightful, wonderful thing for me, because then I could write grant applications, and I got them all funded, at least for the next several years. And we proceeded then over the next several years to do a number of additional, what I would call human experiments, generally very small studies. Later, the next study we did, thinking that one of our limitations was the number of dendritic cells we could acquire, because they were really few. We could only get about 3 or 4 million cells out of these patients, which is a tiny little number. So we thought, well, maybe if we could get 100 million or more, that the results would be even better. So we turned to the use of a recombinant growth factor called FLT3 ligand, which I obtained from a biotech company in Seattle called Immunex, which is now part of Amgen. And they gave us enough material to treat 12 patients. They didn't like the fact that we were going to do this, because they were hoping that FLT3 ligand was going to be a therapy all by itself. That never happened, and probably never will, because it just causes the release of immature dendritic cells from the bone marrow, but the dendritic cells are immature, and immature dendritic cells don't do much. But we did treat these 12 individuals who had advanced colorectal cancer with FLT3 ligand, and we then, after a period of about 10 days, we isolated large numbers of these immature dendritic cells and pulsed them with a synthetic peptide, a 9-amino acid peptide derived from carcinoembryonic antigen. And this particular peptide we knew would bind to HLA-A2, which is a particularly common HLA antigen. Of course, we selected HLA-A2 patients for this study, and we treated those patients with these dendritic cells pulsed with carcinoembryonic antigen. And again, we saw some responses, not as durable or as frequent as the responses we saw in lymphoma, but quite remarkable. And this is an example of a patient who had a pleural effusion and metastases to the lung, again, before and after 3 injections, and the tumor and the effusion had disappeared. So what we discovered from this early trial was that there was a remarkable correlation between the clinical response and the amount of expansion the induction of expansion of antigen-specific T cells that we could measure in the blood of these patients. As you can see here, the patients who responded either with complete responses or stable disease all had substantial expansions of T cells that were specific for the carcinoembryonic antigen that we used as the vaccine. This was very encouraging. We didn't cure anybody, but we had a couple of remissions that lasted 6 to 8 months. So with that background, oh, can't hear me. Sorry, thank you. With that background, I then went to my university technology licensing office, and suggested that we had some exciting technology, and they should help me look for a company to license this technology and develop it for more patients. So we started doing that, but there weren't any companies out there that had any interest in acquiring a cell therapy. Cell therapy was like, what's that? And it was expensive. And so at that point, I worked very hard to try to convince venture capitalists that this would be something important and interesting, and we were successful. And that led to the formation of a company called Dendrion, which licensed the technology. And then a number of my former trainees went to the company and transferred the technology and identified a potential antigen. And once that happened, they were off to the races. Now, they decided, together with their advisors and their business associates, that a better target for using for dendritic cells, better than lymphoma or colorectal cancer or lung cancer, would be prostate cancer. And the reason that they made that choice is because we don't need prostates, I guess. That's one way to put it. So if you induce an autoimmune response to prostate, so what? So there was a great deal of anxiety and worry that through this kind of vaccine approach, that there was going to be induction of widespread, life-threatening autoimmunity. And so that was the basis for the initial choice. Now the company planned to develop vaccines for all kinds of tumors, but they started out with this particular antigen, which was a prostate acid phosphatase, which is a molecule produced by most prostate cells, and they made a genetic fusion with GM-CSF, which is a cytokine that we had published in 1990, causes dendritic cell maturation and activation. So it was a clever idea, and the company then proceeded to develop a manufacturing process, design clinical trials, file IND, and performed a series of clinical trials to assess safety and efficacy. Now, they had no idea, nor did I, that it was going to take 15 years from that point to actually get to an approvable endpoint. And what we learned in the process was that many immunotherapies do not cause rapid disappearance of tumors. In fact, sometimes you see an increase in the actual apparent size of the tumor, which we believe is due to infiltrating immune cells. But in any event, the company eventually was able to demonstrate in controlled clinical trials a statistically significant extension of life. And this curve is eerily reminiscent of the kind of things we saw with monoclonal antibodies that were ultimately approved for breast cancer and lymphoma, respectively. But nonetheless, in 2009, a significant mortality benefit had been demonstrated in hormone-resistant prostate cancer patients, approximately 700 in 3 trials, treated with these autologous dendritic cells that had been loaded with this antigen. Now, in fact, they weren't purified dendritic cells, but the company didn't necessarily follow all of my advice, and they used a very impure preparation, but it worked adequately. And this was the first convincing demonstration that active immunotherapy with a tumor antigen-based vaccine can provide a clinical benefit. The vaccine was well tolerated, and in 2010, Sipuleucel T, or Provenge, was approved by the FDA. Now, I sometimes, but I won't do it today, I sometimes have a slide that I use that addresses, it's a cartoon that talks about the fact that while this vaccine was well tolerated and showed real benefit, it was extremely costly and complex. And I have a slide that shows a pharmacist or a doctor speaking to a patient and handing him this vial that says, "This is a miracle drug. It's a miracle if you can afford it." The company did not like that when I was making these presentations. So I have not been, the company is gone at this point, so I can say whatever I like, but I was an advisor to the company, but this is the way it was. I mean, it was the first iteration of cell therapy, and it demonstrated the proof of principle, but from a practical perspective, it was really a difficult proposition. So for the last 20 years, my lab, one of the things we've been working on has been trying to develop ways of loading and activating tumor-associated dendritic cells in situ, inside the patient, without the necessity of having to remove cells and manipulate them and return them on an individualized basis. And we published a paper last year in the journal Nature describing an important, I think, important discovery as to how this can ultimately be done. And it was based on the observation that allogeneic tumors that are genetically not identical to the host, if you inject tumors that are not identical into a host, they get rejected. And that wasn't a startling discovery at all. The startling discovery was that the rejection process, while it was mediated by T cells, was not initiated by T cells, but in fact was dependent on antibody. And so by studying the response to allogeneic tumors, which are always eradicated, we were able to come up with the mechanism responsible and ultimately begin to take advantage of this mechanism. And in essence, I summarize the critical finding here, which is that it turns out that when antibodies, in this case alloantibodies in the host, were binding to the tumors, that binding did not kill the tumors. What it did, however, was to enable those tumors to to bridge to dendritic cells in the environment through the Fc receptors on dendritic cells, which engulfed the entire tumor, processed the entire tumor, and presented multiple antigens, including host-restricted antigens to T cells, and drive a very broad T cell response. So we then proceeded with that set of observations to see if we could translate or transfer this approach to an autologous tumor setting. And we treated a wide range of mouse tumor models and showed that data in the paper, and I will just briefly go through that here. But what this slide shows is simply that when we transfer a tumor from mouse A to mouse B, and these mice had the same MHC but differed in other genetic backgrounds, the tumor is normally rejected. You can see that here on the right, and here's another tumor on the left. We did a pancreatic tumor and a melanoma. But if we eliminate the B cells or the antibodies, the tumor keeps growing. And that's the same here. The tumor just keeps growing. So this was a big shock that if you eliminate antibodies from a host, that the tumors would keep going, that somehow the T cells were dependent on it. But that's when we went on to identify that mechanism. And then we ultimately figured out that if you could transfer tumor-binding antibodies to an autologous host and simultaneously administer a dendritic cell stimulus, you could effect cures in a wide range of tumors. So I'm going to go very quickly through these tumors that we've treated. These are all in mice. Some of them are cell line tumors. Some of them are genetically engineered tumor models. And I'm sorry about the complexity of these slides, but in essence, what you see in the red line here is cure of a B16 melanoma. But the cures only appear if you simultaneously treat the animals with tumor-binding antibody and dendritic cell stimuli. In these cases, we used as stimuli either CD40 ligand or CD40 ligand with other things. And you'll see that these patterns are very similar. This is a Lewis lung tumor where we can cure the tumor reliably if we treat the animals with this combination therapy. This is the 4T1 breast cancer model. All of these models have been well studied. In this case, the breast cancer reliably metastasizes to lungs. We treat the primary tumor. We inject the primary tumor with our combination approach. That primary tumor disappears, and all the metastases also disappear, even though the metastases were not directly injected. And you can see the metastatic lesions in these lungs, and in the animals that were treated with the combination therapy, they're gone. And then finally, this is a genetically engineered model of malignant melanoma, extraordinarily difficult to treat. At least no one else has ever been able to cure these animals as far as I know. But again, we treat them with combination therapy. In this case, we're using a combination of immunoglobulin that binds to the tumor and plus TNF and CD40 ligand. And again, you're seeing tumor cure. Well, we added in the paper one last figure. I don't think it was absolutely essential because none of the reviewers ever mentioned anything about it. And that was in vitro data to show that this approach could potentially work for human tumors as well. In these cases, we isolated tumors from patients with lung cancer. Indeed, 2 patients with mesothelioma, which is probably why I was invited. Because I had a collaborator working with me who was a thoracic surgeon, and he was able to get these cells for us. But more importantly, not just the tumor cells, he was able to get dendritic cells from the tumor and also from bone marrow, because the ribs were being removed, and we could isolate bone marrow-derived dendritic cells and study them as well. But anyway, what we showed was that by incubating these, in this case, bone marrow-derived dendritic cells from mesothelioma patients, either with autologous immunoglobulin and dendritic cell stimuli, or allogeneic immunoglobulin and dendritic cell stimuli. And if we incubated them with allogeneic stimuli, we got remarkable activation of the dendritic cells, uptake of the tumor, processing of the tumor, and presentation of the tumor antigens, so that to autologous T cells, as indicated here, this is the T cell response of these 2 mesothelioma patients. as measured by tritiated thymidine uptake, all in vitro. So we've done in vitro vaccination, immunotherapy with T-cell responses based on exactly the same combinations that we were using in the mouse models. So just to summarize the published data, allogeneic tumor-binding antibodies can initiate a multi-step process that results in potent anti-tumor immunity by bridging tumor cells to dendritic cells via their FC receptors. I'm going to show you a cartoon that illustrates this. But once activated, the dendritic cells ingest, process, and present multiple tumor antigens to T cells, which proliferate and kill the tumor cells wherever they are throughout the host. The approach was shown to eradicate pancreas, lung, breast, colorectal, and melanoma tumors in mice, and was well tolerated. Now, I say it was well tolerated because the mice didn't complain. They didn't die. But obviously, we're looking forward to seeing what happens in vivo in humans, but the approach appears to work in vitro in terms of activating human tumor-reactive T cells. Now, this is the cartoon that I mentioned, because I know I've spoken pretty fast, and believe me, that paper in Nature was a hard read. But essentially what we showed was that tumor-binding antibody by itself really doesn't do much. And I go back to those early slides where I showed you the Herceptin and the rituximab slides. I honestly believe that the reason why tumor antibodies do so little is because they don't have a really robust effector mechanism, unless you provide another signal, in this case a signal to activate these tumor-associated dendritic cells. In tumors, almost all of the myeloid cells, dendritic cells, macrophages, myeloid-derived suppressor cells, they're all promoting the tumor in general. They're all asleep at the wheel, but they're reversible. They can be woken up. And that's what we accomplished by simultaneously treating with these tumor-binding antibodies and these dendritic cell stimuli. And ultimately, the dendritic cell can do its thing. It's very powerful. It can take up the entire tumor, all the antigens. They're all processed. They're all presented. And provided that there are T cells somewhere with a receptor for these particular antigens, there will be a response. And that's how this proceeded to induce this level of activity. So in summary, the advantages of this type of an approach is that it's extremely potent against diverse tumors. Most of the tumors we treated in mice are resistant to checkpoint blockade. Conceptually, these combinations are relatively inexpensive. This is not personalized cell therapy. The cells do not have to be manipulated in vitro. Everything is done with an injectable small molecule or small molecule combination. The challenge, of course, is that this approach has yet to be tested in humans. Hence, a company has recently been formed that has licensed this technology and hopefully will be developing it very soon. And they're doing things that beyond what my lab can do. In particular, not just taking mixtures of molecules and injecting them, but actually creating antibodies that are now modified so that they are chemically modified to contain the dendritic cell stimuli. So you actually have single molecules with all of these desired properties, and we'll see what happens. Just to summarize, and I apologize for not having, my purpose was not to review other immunotherapeutic approaches, but we all know that immunotherapy can induce durable tumor regression in a growing range of tumors. The most effective immunotherapies rely on tumor-attacking T cells. There's lots of interest in NK cells and in other types of cells, but the current data would suggest that it's the T cell that needs to be used or targeted. Combining, in our case, in our particular technology, combining tumor-binding antibodies with dendritic cell stimuli induces very potent T cell-mediated anti-tumor immunity to a wide range of cancers. In the future, immunotherapy, this is probably obvious to this audience, will be comprised of combinations of products that engage different components of the immune response. I was at Merck 5 months ago, gave a talk on this general subject, and they were proudly informing me that with their single PD-1 antibody, they have 200 clinical trials ongoing. That was back in March. 200 clinical trials. Now think about that. 200 times 10 to, I don't know, 10 to 40 or 50 million dollars. That's a billion-dollar bet. And they're not alone. They were telling me that, well, we're at 200 and Bristol Myers is only at 150. And that doesn't include all the other companies, big and small. So the landscape, to say that the landscape has changed would be kind of not doing it justice. This is a complete transformation of the biopharmaceutical industry, whether we think it's a good idea or a bad idea. And checkpoint blockade is obviously here to stay. The argument that Merck makes, and this is, I know, familiar to many of you, is that because these antibodies, again, one size fits all, in the case of either the PD-1 or the PD-L1 antibodies, and they can combine them, because they're relatively well tolerated, they can combine them with anything you can think of, whether it's chemotherapy, gene therapy, radiation therapy, or other novel molecules. And that's what they're doing. Essentially, they're making these combinations. So, typically with one other molecule or more. So my personal prediction is that ultimately what these very large companies will do, or they want to do, is to recreate or mimic what Gilead has done with their treatment of hepatitis C. And Gilead was the first to combine multiple molecules into a single therapeutic therapy or platform. And today, hepatitis C viral infection is cured. 99% of those viral infections are cured. And 5 years ago or 8 years ago, we would have said that's impossible. And all they did was to combine 5 different antivirals, each of which targets a different component, put them into one pill, and they cure 99% of hepatitis C infected individuals in this country. That takes about 3 months. In any event, I know it's going to be a little harder. I don't mean to suggest that it's going to be quite that simple, but I believe that's what these very large companies are trying to do at this point, and it's going to be very interesting to see how it evolves over the next 5 years, 5 to 10 years. And it's exciting to be part of it. My hope is that our approach will be part of the overall strategy as time goes on. My lab is a student lab. This is a photograph of the members in it. All of these individuals are either graduate students or postdoctoral fellows. They all leave, which is very sad for me. But there they are. The fellow here on the right, Yaron Karmi, is the first author of our Nature paper. And all these other guys, about half of these individuals have left. This was a photograph from about a year ago. And several of them are now assistant professors at universities around the world. So I'm proud of this group and very happy to have finished my presentation.